Thanks for joining us. My name is Jack Rychik, and I'm a pediatric cardiologist at the Children's Hospital of Philadelphia. Welcome to Pediatric and Congenital Heart Talks, a series of lecture presentations and discussions on interesting and important topics in our field of pediatric and congenital heart care. In this series, we will share insights on a variety of topics, offer new perspectives on some basic principles, introduce novel concepts and innovations, as well as identify what needs to come next to solve challenging problems in our field. Our objectives are to provide education on a variety of topics, but also perhaps to stimulate some provocative thought. We'd love to hear from you and get your questions and ideas and thoughts on these discussions. You can contact us at this email address, chophearttalks@email.chop.edu. Okay, let's go ahead and get started. Care for the newborn with complex congenital heart disease is a complex matter that involves multiple specialized services and domains. Infant wellness within a context of family wellness is critically important during this fragile period of time of newborn life. It's my pleasure today to introduce to you Dr. Amy Jo Lasanti. Dr. Lasanti is a nurse, and who better to be able to explore this area of infant wellness than the critical role that our nursing colleagues play in the care, again, of these infants with complex congenital heart disease. Dr. Lasanti is a nurse scientist and clinical nurse specialist for cardiac nursing at the Center for Pediatric Nursing Research and Evidence-Based Practice. She's an adjunct professor, adjunct assistant professor at the University of Pennsylvania School of Nursing. And she's going to speak to us today about the topic of what does nursing science say about improving outcomes for infants with complex congenital heart disease and their families. It's my pleasure to introduce to you Dr. Lasanti.
Thank you so much, Jack, for that warm introduction. It is an incredible privilege to be here with you to speak about this really important topic. As we get started, I do have a few disclosures to share with you. I will be presenting research funded by the American Nurses Foundation, the National Institute of Nursing Research, as well as from the Cardiac Center here at Children's Hospital of Philadelphia. So what does nursing science say about improving outcomes for infants with complex congenital heart disease and their families? This is a big topic. And as we get started, I think it's really important just to talk about what nursing science is. Like any other scientist using the scientific method to conduct research and generate new knowledge, nurse scientists are nurses whose science is conducted to generate knowledge that can especially inform nursing practice. The provision of high-quality, optimal, evidence-based nursing care is reliant upon the generation of knowledge within nursing so that nurses have evidence upon which to base their practice. There have been amazing nurse scientists that have contributed valuable work to our specialty within pediatric cardiac nursing. Dr. Nancy Pike has, of course, she has a whole body of research on the Fontan population, and specifically with adolescents and even into adults who are living with single ventricle disease. Dr. Karen Uzark has helped us understand more about the quality of life of children living with congenital heart disease. Dr. Kathy Masato has done an amazing job of identifying the risk as well as the prevalence of developmental delay in children with congenital heart disease. And Dr. Patricia Hickey and her colleagues with Dr. Jean Connor and Martha Curley, they have really done an amazing job to describe the impact that higher levels of nursing education and experience, as well as critical care nursing certification, that these are significantly associated with improved patient outcomes within pediatric cardiac patients, showing a reduction in complications as well as a reduction in deaths. And then Dr. Sandy Stavitsky has a whole body of research on pediatric delirium, describing the prevalence and how we can manage pediatric delirium in the cardiac ICU population. So this is not an exhaustive list, of course. I'm going to give my last example from Dr. Barbara Medoff-Cooper, who was actually my mentor early in my career. She, of course, has done research in feeding and in growth in infants with congenital heart disease, and I just feel like I'm standing on the shoulders of giants, as they say. There have been a cadre of nurse scientists that have led the way in the past and whose work that we can use as a foundation to continue to build the science of nursing within the pediatric cardiac subspecialty. I do want to spend some time sharing with you some of my work and where my program of research has headed and where it's been and where I think it's going to be headed in the future. So just to give a little bit of background for those listeners who may not know, congenital heart disease is the most common birth defect, impacting almost 1% of all births worldwide. And that a subset of these infants are those born with complex congenital heart disease, who require neonatal cardiac surgery to survive past the newborn period. Prior to the 1980s, the vast majority of these infants died. But of course, surgical and medical advancements over these last 4 decades have drastically improved survival rates. Yet we have learned that congenital heart disease is really a chronic illness. Although the plumbing of the cardiovascular circulation can be rerouted, palliated, or completely fixed to mimic a normally developed heart, there can be many long-term morbidities, as some of those nurse scientists that I mentioned have helped to build the evidence for. One issue that I am particularly concerned about is that these infants are at higher risk for delayed neurodevelopmental abnormalities. Research to date has found many variables contributing to neurodevelopmental outcomes. These include, but not limited to, the complexity of congenital heart disease, underlying genetic abnormalities, decreases in cerebral perfusion, lower birth weight, and longer hospital lengths of stay. However, together, these explain less than 1/3 of the variance in neurodevelopmental outcomes. Very few studies have examined the social, environmental, and family variables that contribute to these outcomes. And I believe this is where nursing science can address a critical gap in our understanding of how we might be able to improve these outcomes. Pediatric nursing is focused on the holistic care of children and their families. It's what I love most about nursing. We are concerned with the developmental, environmental, physical, social, emotional, and spiritual needs of our patients and families. Importantly, parent mental health is known to exert a powerful influence on child neurodevelopment, behavior, and emotional well-being. Even within the CHD population, there's emerging research demonstrating that maternal mental health is often a stronger predictor of child neurodevelopmental outcomes than medical variables, including even the severity of congenital heart disease and surgical factors. For me, as a CICU nurse, early in my career, I wanted to know how we as nurses could make an impact in a measurable way to reduce the extreme stress that it was clear these parents were experiencing and potentially improve the mental health outcomes. And so that is where I focused my dissertation work and subsequent early research. In fact, at the time, it was such a new area of study that I needed to create a theoretical framework upon which to base my work. And so that's exactly what I ended up doing. I'm going to give you a very brief overview because I think it will provide a valuable context to the research. The themes from this model are based on a synthesis of 4 decades of research in parents in ICU settings, so in both the pediatric and neonatal ICU settings. And then I was able to refine this model through a qualitative study of 14 mothers in the CICU that participated in 3 focused groups. We use directed content analysis to clarify specific foci of stress for mothers, and we use these themes from the analysis to validate and refine the model, which is called the PCICU Parental Stress Model. It posits that stressors arise from 3 categories and combine to create a stress response in parents in the CICU, or the Cardiac Intensive Care Unit. And so I'm just going to briefly go through each category and highlight some of the greatest stressors. So within the infant category, one of the highest sources of stress from parents that is cited in research is infant appearance and behavior. And I'm sure this comes as no surprise when we see these infants with their lines, tubes, and wires in them. When parents have to grapple with seeing their child crying or in pain, that appearance of the infant can be extremely stressful for parents. Within the environment category, the ICU sights and sounds, the vast numbers of technologies that we use to care for these patients can be completely overwhelming for our parents. And you can see here, many times these infants have open chests and they're on ECMO and they have multiple infusions and they're on multiple monitoring devices. And it can be hard for parents to even take that all in. From within the parent category, parental role alteration is another one of those most highly cited stressors for parents. And what that is parents, when they don't know how or they're feeling unable to care for their child, to hold their child, to protect their child, doing some of those innate instinctual feelings as a parent when you have your child, a lot of that is stripped away because they're given intensive care and they're not able to hold their baby or touch their baby, and it can be a very paralyzing feeling. And so that's what parental role alteration is, and it can be a great source of stress for parents. And so these stressors then combine to elicit a stress response in parents that are both psychological, such as mental health symptoms of anxiety or depression, as well as physical, such as elevated blood pressure or stress hormone levels. So let's examine the levels of mental health symptoms that have been measured in parents in cardiac ICUs to give you a sense of just how real this problem is. These 5 studies are to date the only known reports of anxiety symptoms for mothers of infants in the cardiac ICU. You can see the first 3 studies are studies that I have conducted, and there's one site that is outside of the US, you can see there. This bar graph represents state anxiety scores of mothers as measured by the State Trait Anxiety Inventory. This is a well-validated instrument that has been used for almost 4 decades. State anxiety is the amount of anxiety symptoms experienced right now at this very moment. So when mothers are completing the survey, it gives that level of anxiety. For these mothers, the scores represent the amount of anxiety symptoms reported by mothers in the postoperative period after their infant's cardiac surgery while they were in the cardiac ICU. It's also measures, the State Trait Anxiety Inventory also measures trait anxiety, which is really more of a personality characteristic. It reflects one's tendency towards becoming anxious. You can see along the bottom the various sample sizes of these mothers, and they range from about 20 to 62. And just to orient you here is the 50th percent of normative scores for women of childbearing age. And here is the 75th percentile. These values around the mid-40s exceed the 75th percentile of normative values. This is similar to the means of neuropsychiatric patients with anxiety disorders. These are very anxious mothers in the CICU. It's important to mention that for those first 3 studies that I conducted, I also report the trait anxiety scores or mothers' tendency towards becoming anxious. Their values were all normative within the mid-30s. So we didn't enroll highly anxious mothers, and those state anxiety scores are really reflective of their experience in the ICU. That middle study, I also enrolled fathers, mother-father pairs, and this is the first report. This paper is still under review, but you can see here that we're also seeing father state anxieties in the low 40s. And again, to orient you, you can see that the fathers are at the 75th percentile as well. So these are very anxious fathers. That same study, I had parents complete both anxiety and depression tools. The Center for Epidemiological Studies Depression, or the CESD, is a well-validated tool that has a cutoff score upon which you can determine likelihood for meeting criteria for clinical depression. You can see that a little more than half of mothers and over 1/3 of fathers scored at or above the cutoff score, meeting criteria for likely clinical depression. And this difference was not statistically significant. Another one of my studies enrolled 30 mothers of infants in the pediatric cardiac ICU. And we see that approximately half of mothers meet criteria for clinical depression. And we found this in both the preoperative as well as the postoperative period of their infant's cardiac surgery. So again, to orient you, for the population at large, depression is experienced by 10% of women. And postpartum depression can be upwards of 15 to 20%. So mothers in the CICU far exceed these rates. So parents are experiencing extremely elevated stress responses as measured by anxiety and depressive symptoms. However, what are those stressors that may be contributing to this stress response in parents? And are any of them modifiable or able to be targeted for intervention? The Parental Stressor Scale Infant Hospitalization, or the PSSIH, is an instrument that has 3 subscales that, as you can see here, those subscales correlate with those stressors that I mentioned earlier: infant appearance and behavior, the ICU sights and sounds, as well as parental role alteration. For those studies that I briefly mentioned, I also had parents complete the PSSIH, and I was able to examine the relationship between these subscales and the parental stress responses of anxiety and depressive symptoms in some of my studies using multiple regression analysis. For this study of 62 biological mothers of neonates admitted for cardiac surgery in that first month of life, we again measured that parental stressor scale infant hospitalization and at the state trait anxiety inventory. This analysis found that the combination of trait anxiety and parental role alteration predicted over a quarter of the variance in state anxiety scores, highlighting the need for mental health screening of mothers to identify mothers at risk and enhancing that parental role in the ICU. In a separate study of 30 mothers, we looked at the relationship between those stressors and the stress response of depressive symptoms in mothers, and this was in the preoperative period. And again, we found that parental role alteration significantly predicted actually 62% of the variance in depressive symptoms. In that study that I mentioned where I enrolled 28 mother-father dyads, the reason why I strategically enrolled dyads was in order to examine differences in stress and stress response based on sex as a biomarker. Many studies have demonstrated differences in the way male brains and female brains perceive stress and react to stress. So we measured stress, anxiety, and depression within 1 week of their infant's cardiac surgery. And we ask parents to complete also this dyadic adjustment scale, which measures the quality of relationship between partners. Using linear mixed effect modeling to account for the anticipated correlation between dyads of the same infant, we found again that parental role alteration contributed to both anxiety and depressive symptoms regardless of parent sex. In addition, a lower level of agreement between the dyads, as measured by the dyadic adjustment scale consensus subscale, predicted higher depressive symptoms. So I believe we're observing an important pattern emerge in the relationship between parental role alteration and mental health symptoms of anxiety and depression. This was actually really exciting for me because out of the many stressors, I believe this is one of the most modifiable factors that we can target for nurse-led intervention. There's not much nurses can do to change the appearance of an infant if they come back from the operating room with an open chest on ECMO. But we can improve the role that the parents have at the bedside and engage them in the care of their infant. So how do we do this? How do we provide that connection? How can we enhance parental role in the CICU, especially with so many barriers such as the hemodynamic instability of infants, the many lines, tubes, wires, and other technologies present? One of the key ways parents connect with their infant is by holding them. I would argue it's one of the most essential ways parents can bond with their infant. Yet, at the time when I was starting this work, this is probably between 5 to 10 years ago, it was clear that there was a barrier in our unit for holding, particularly with some of the lines, tubes, and wires. And transthoracic intracardiac catheters was one where patients were not allowed out of bed if those lines were in. So we began a line of clinical inquiry where we conducted an international benchmarking study of 43 unique institutions from around the world. In this study, we specifically asked about whether patients with transthoracic intracardiac catheters were able to be held or mobilized out of bed. And we found that approximately half of the centers did permit mobilization out of bed with these lines. So that provided some preliminary evidence for us to begin an interdisciplinary initiative to tackle how we could safely mobilize pediatric patients out of bed with these transthoracic intracardiac lines. There was really nothing else in the literature to help to guide us on how to do this safely. So we worked with our team of the surgical team and the ICU team and physical therapy team to come up with a method to dress and secure the lines. You can see that pictured here, what our final standard became. But we wanted to make sure that there would be minimal risk for dislodgement. We pilot tested this and then developed standard and procedures to educate our staff. We also developed these holding and mobility guidelines to provide clarity regarding the other lines, tubes, and wires that nurses could have some decision-making about which patients could be held and which patients may need attending physician and a team approach to be able to get those patients mobilized out of bed. So we then examined a total of 1,358 patients from across a 5-year period from 2014 to 2018. This was 2 years pre and 3 years post implementation of our standards and procedures. We specifically examined the activity and positioning documentation for patients with transthoracic intracardiac catheters that were in place. And we showed that after implementation of our standard dressing and securement, our holding guidelines, and procedures for mobilization out of bed, that out-of-bed documentation significantly increased for patients, and they experienced significantly more days out of bed. Around that same time, we were developing nursing standards and procedures for cardiac infants to be held skin to skin, also known as kangaroo care. This occurs when parents are able to hold their unclothed, diapered infant to their bare chest. There's a whole body of research in skin-to-skin care in neonatal intensive care units, but it was not well described in cardiac infants. We even did a 8-week kangaroo-a-thon where we sort of did education and provided energy around the staff to really get excitement about having the nurses offer skin-to-skin care to their patients and parents. It was the first unit-based project described in the literature to support infants to be held skin-to-skin. So while we were able to establish these unit-based standards and procedures to support nurses to enhance the role of parents through holding, I really wanted to understand more about the outcomes of skin-to-skin holding for both infants and their mothers, especially because I really thought this was a key way that we could enhance the parental role of mothers in the cardiac ICU. I believed that based on the research in the NICU that skin-to-skin care would be a non-pharmacologic nursing intervention with the capacity to reduce infant stress, to promote overall comfort and physiologic stability for infants, as well as potentially reduce maternal stress and anxiety in the CICU. So I was able to incorporate our skin-to-skin care procedures and holding guidelines into a research protocol so that we could systematically study these outcomes. If you recall my model describing the parental stress in the pediatric cardiac ICU, stress response can be both physiologic as well as psychologic. And so the hypothalamic pituitary adrenocortical axis is activated in response to stress, resulting in cortisol production that actually can be reliably measured in saliva. And so the aim of my study was to determine the effect of skin-to-skin care on physiologic stress using salivary cortisol for both mothers and infants. I also looked at physiologic stability of infants, pain scores, and behavior states, as well as the psychologic stress response of state anxiety in mothers. We used a baseline response pair design with mother-infant dyads acting as their own controls before, during, and after skin-to-skin holding at 2 distinct time points. So we did this once in the preoperative period and once in the postoperative period after these infants were extubated and off narcotics and pain medications. We conducted this in the CICU and the step-down unit and enrolled a convenience sample of 30 infants admitted preoperatively for congenital heart disease and their biological mothers. As I said, we obtained these measures of salivary cortisol and pain and behavior state of infants, as well as state anxiety and salivary cortisol for mothers. And we obtained these at 3 sort of distinct time points in the holding. So we would place infants in their mother's arms for 1 hour of skin-to-skin holding. And we collected data immediately pre-skin-to-skin, 30 minutes into skin-to-skin holding, and that's because it takes at least 20 minutes for the cortisol levels to change in response to either a stressor or a stress reduction intervention, and then 30 minutes after skin-to-skin care had ended. So really briefly here, you can see some of our results. You could see on the left here the preoperative time point, and on the right the postoperative time point, time 2. And these three times that we collected data. So right here is your pre-skin to skin. I can get that, there we go. Pre-skin to skin, 30 minutes during skin to skin, and 30 minutes post-skin to skin. And you could see at both time points, maternal state anxiety scores were significantly reduced during skin to skin care and actually remained significantly lower after 30 minutes after skin to skin. And we found that at both time points. Maternal salivary cortisol, we saw significant reductions during skin-to-skin care and even after skin-to-skin care. This was found at both pre- and post-operative time points. For infants, we found significantly reduced pain scores at both time points. We also found significantly reduced behavior state scores. And what this means is that infants were actually in a more sleeping or quiet state during skin-to-skin holding. We did not find any differences, which was what we wanted to see. We wanted to show that this was safe for infants. So we didn't see any significant differences in their temperature, in their heart rate, except for in the preoperative period, we did see a significant decrease in heart rate in the preoperative period that was coupled with actually a significant increase in their systolic blood pressure. We also found significant reductions in respiratory rate. For infant salivary cortisol, we found no change in the from pre to during skin-to-skin care. So that showed that this was putting infants into skin-to-skin care did not elicit a stress response in these infants. We did see a significant increase in salivary cortisol after infants had been placed back into their cribs. I think some of this could have been from the maternal separation. So infants were so comfy and happy in skin-to-skin holding that when we placed them back into bed, that could have been stressful for them. It also was very close to their next feed, and they were much more awake and alert, and so that could have elicited a little bit of a stress response. So we were very encouraged from these key findings of our skin-to-skin care study. Physiologic stability was maintained during skin-to-skin care for infants at both the preoperative and postoperative periods and did not elicit a stress response. Results suggested that skin-to-skin care is a promising strategy to support infant comfort, reduce pain, and promote sleep. For mothers, patterns of state anxiety and cortisol demonstrated sustained reductions in both psychologic and physiologic stress responses during and after skin-to-skin care at both time points. And as hypothesized, skin-to-skin care was demonstrated to be a powerful nurse-driven intervention to mitigate the negative stressor of parental role alteration. Our findings are similar to those described by Dr. Tandy Harrison, another nurse scientist who has studied skin-to-skin care in infants with congenital heart disease. And her work described that skin-to-skin care supports infant autonomic nervous system functioning and even early cognitive function and learning in infants. So while our study was the first to report biobehavioral outcomes of skin-to-skin care for mothers and infants with congenital heart disease, I believe it was particularly successful at improving maternal stress response because it enhanced parental role for mothers in the CICU. We were able to use our holding guidelines and skin-to-skin care protocols for the study, and we also articulated these in the literature so they could be replicated at other centers. Future research is needed to further the science of nursing in congenital heart disease. Lots of exciting work needs to be done to continue to demonstrate how nurse-driven interventions may support infant development as well as parent mental health. For example, if we support parental role in the CICU and foster attachment and mitigate parent stress and mental health symptoms, can we have a long-term impact on both parent mental health and infant neurodevelopment? Can we identify other nurse-led interventions to improve developmental outcomes, such as ways to reduce infant pain or stress? I would like to close with a brief story because I do believe that stories are powerful to help illustrate some of these deep concepts that I've discussed. This sweet child was born premature with complete heart block, a very low underlying heart rhythm, and required temporary pacing until she grew big enough for a permanent pacemaker. She spent weeks upon weeks in an incubator, not able to be held. And I was a clinical nurse specialist at the time and working in the cardiac intensive care unit. And I worked with the team to offer an opportunity for these parents to hold their baby. Both the mother and the father were able to hold their baby for an hour. We even took pictures of them together. Because she had to wait so long, we ended up transferring her to the neonatal intensive care unit to grow. And unfortunately, she developed some other complications and ended up dying before she could get her pacemaker. Several months later, I received a letter from her mother, and enclosed with the letter was a family picture, the only family picture that they had ever taken. And it was at that one opportunity that they were given to hold their infant skin to skin. I want to read a few quotes from this mother's letter so you can hear her heart. My daughter was so little, and the tubes and wires were so many. I didn't know how to touch her, how to hold her, how to be a part of her life. You gave me the confidence to try. You put her into my arms and really did give me that once-in-a-lifetime chance. I was scared to touch her, not wanting to hurt anything. You made that all okay. Better than that, you made it happen. I can't thank you enough for putting our daughter in our arms and helping me to be a part of her short life here. You made me feel human and cared about, and that things might be okay. Did you hear it? Did you hear this mother's stress and fear from seeing the appearance of her fragile child, seeing all the lines, tubes, and wires, and how that made her feel afraid and anxious? Did you hear her desire to connect with her child, to find a way to be her mother? And how that one act of holding her child made all the difference in the world, not only in that moment, but it will be a memory that she holds on to for the rest of her life. Nurses have the opportunity and privilege to initiate and facilitate those moments for families that can make a huge difference in their journey of raising a child with congenital heart disease. Nurses are uniquely positioned to provide this essential holistic care. It's up to nurse scientists to articulate the unique contribution of nursing through nursing theory, through innovative measurement strategies, and through both qualitative and quantitative methods. The science is still very young, and future work is needed for pediatric cardiac nursing science. My goal for my program of research is to hopefully answer some of those questions. And I hope that many more pediatric nurse scientists will join in the journey to generate new knowledge in order to improve outcomes for infants and children born with congenital heart disease and their families. Thank you.
Amy Jo, that was fantastic. It was just a wonderful synopsis of the work that you've done, where we are, and very much outlining the deficiencies and the multitude of questions that need to be asked. My goodness, this area of investigation, of research, the area that you're focusing your attention on, is so essential. We all know that there is the fragility and the plasticity of infant life, neuronal connections that are being formed and such. And the impact that minor changes in behavior and how environments are structured is so critical. We know it's important, but we don't know exactly how. And, to date, your talk reminds me of this, to date, much of what we've been doing with nursing is, to a degree, creating efficiencies. And your work, and the work of many, many others, begins to have us take pause and begin to pay attention to perhaps efficiencies are good for the short term as to what we need to do to quickly heal a newborn, get them out of the hospital, get them home at a reasonable healthcare resource cost, but that an investment in what we do at this point in time is so critically important for their long-term outcome. So here's going to give you a little bit more information, then I'll get to my question in a moment here. But, your work is so fascinating. It dovetails nicely, as you know, with some of the work that we've done prenatally. So we've taken some of your more sophisticated elements, and we did this in a very rudimentary way about 7, 8 years ago now. We looked at maternal stress in the prenatal state. mothers who are carrying fetuses with congenital heart disease. And we used the state trait anxiety scores as well, and those scores were off the wall. And we used the dyadic adjustment score as well, realizing that, of course, naturally, as you would anticipate, partner satisfaction plays an important role in perhaps mitigating some of that maternal stress. So stress levels are very high. What we did notice, almost secondarily, was that as we were repeating the assessments at serial evaluations prenatally, we saw reduction in the state and trait anxiety scores, indicating that encounters, the multiple fetal prenatal encounters that we systematically undertook every 4 to 6 weeks, was reducing the overall anxiety. So to a degree, that's an intervention. And so here's where I'm getting to my question, to you. The science is young, the field is young, the questions are many. You've already alluded to one, the skin-to-skin aspects. What are your thoughts about how one takes this work into the direction of interventions, really empowering nurses with the science and the knowledge to begin to perform intervention in the same way that we adjust a drip, we provide changes in mechanical ventilation for respiratory aspects. There's no doubt that nursing care and nursing interventions are an investment that's going to have an important impact on the overall short and lifetime outcomes of these patients.
Mm-hmm. No, I think you bring up a couple really great points there. I think number one, we have a lot more to learn. And so looking at the trajectories of stress and parent mental health symptoms from the time we meet them at diagnosis, through the prenatal period, through their journey in the cardiac ICU and step-down unit, and then when they go home, we really have no studies to go on right now that really has that overarching trajectory to describe really who is at most at risk, right? Who are the parents that, for all parents, we should give them XYZ intervention? Is it depressive symptoms that actually have more of an influence on child neurodevelopmental outcomes in congenital heart disease? Is it anxiety? Is it stress? Is it that dyadic adjustment and the issues that are ongoing within the partners, because this is an incredibly stressful experience? We don't know that now, and I think the more we can learn about these trajectories of parent mental health over time, and if we can start to identify which parent mental health symptoms or stress experiences sort of seem to be influencing the child developmental outcomes, then we can better target interventions to support both parent mental health, but also the infant's neurodevelopmental outcomes. Because I do really think, and one of the things I teach the nurses about and I continue to talk about is that we have to stop treating these infants like they're on an island, that it's just the infant, right? These infants are within a family unit that is dynamic, and there's a home environment. There are social determinants of health. There's a bigger picture here that I think there's just so much that we need to learn about so that we can then target some of those interventions.
Yeah. And an area that is very much modifiable. The way I think of things is, you characterize the situation, you see what variables influence particular outcomes, but so much of what you're studying is to a degree modifiable through the hands of the providers, which are primarily the nurses. Mm-hmm. So this is just such exciting work, and I want to sort of congratulate you and encourage you to continue to do this. A point about cortisol. So the cortisol is a funny compound, if you will, in terms of its generation, because it is fight or flight, released in both of those circumstances. And, parents are in a fight when they're dealing with this. And I think there's so much of what you bring to the table as to how you incorporate that cortisol release. And the effectiveness of that cortisol release is what then, in conjunction with what you bring to the table, that either results in an empowerment for families and parents, and perhaps a better outcome with a higher cortisol level, versus where in some other family units, the cortisol is inefficient in creating that fight, and it results in stress that then disintegrates the infrastructure that's necessary to support themselves and the infant. So, and I've sort of come to this conclusion only because we similarly have not found a correlation between salivary cortisol levels and outcomes based on our fetal assessments. Any other end outcome measures you're looking at? Are you following your patients long term, those that you're studying as neonates?
So I'm actually in data analysis right now for a study that I conducted during my postdoctoral work at the University of Pennsylvania, where we enrolled. It was some of that preliminary data that I mentioned about that 28 mother-father dyads. I also had parents provide salivary cortisol samples during that study at wake up, at 30 minutes after they woke up, and then at bedtime, so that we could look at exactly what you're talking about, these cortisol levels as a picture of sort of that amount of stress response that parents are experiencing at that time. And so cortisol awakening response is that change from when they wake up to 30 minutes after they wake up, and it's been associated with some mental health outcomes in other populations. And so I'm just starting to dig into that data. I wish I could share some of those results with you. I'll have to come back and do that another time. But really trying to look at whether cortisol awakening response can be associated with any of the mental health symptoms that we see in the CICU. But I also have post-traumatic stress data on these parents at 3 months. So I'm very interested to seeing which parents are most at risk for PTSD when they go home. We know that about a third of mothers and fathers may experience enough post-traumatic stress symptoms that impact their everyday lives, but we don't know which parents, are at risk for that or not, and who needs that intervention, or what we can be doing to support them in the ICU to prevent that at home. And so I'm hoping, maybe cortisol could be a biomarker that could help us to identify that. So I am looking at that. I think the other thing I'd like to mention that you mentioned is this idea of allostatic load. And so that was described by Dr. Bruce McEwen, which is this idea that it's a wear and tear of stress on the body over a long period of time. And some individuals, because they're under so much stress, then they're unable to sort of mount that stress response. And so I think there's a lot of work to be done to really describe the process of allostatic load in these parents. We don't really know, but we know that they're under a lot of stress when they go home, and that because these children deal with feeding and growth and all kinds of other issues, that they're under a lot of pressure for a long time. And so I think it's an important concept that we could continue to examine. And there's lots of ways that we can do that through measuring. There's other biomarkers that you can integrate to sort of get an allostatic load measure.
Wonderful. So let me switch gears briefly here for a moment and sort of shift towards your career and what you're doing right now. How did a younger Amy Jo Lasanti, who was a bedside nurse, sort of fall into this particular business and get inspired to do what you're doing? You mentioned some of your role models early on, legendary folks who we all know within the nursing realm, cardiology realm, as well. But what was it in particular, experiences or particular incidences that sort of made you say one day, well, I'm doing what I'm doing here, but I need to do something more? Tell us about your story.
It's a good question. It was a very step-by-step process for me, almost of, I was an ICU nurse and I wanted to make a difference. I knew that I needed to go back to school if I wanted to make a bigger impact on the care that we were giving and in understanding, how to make change in the environment. And that was sort of where it was at. I wanted to make things better. So I applied to Widener University. I wanted to become a clinical nurse specialist because the CNS is really that role that is a change agent in the unit that focuses on nursing practice. I very much loved the practice of nursing. And so as I thought about other roles, there's great advanced practice roles within nursing. You can be a nurse midwife or a nurse anesthetist, a nurse practitioner. But many of those I felt for me was sort of leaving the heart of nursing practice. And so I applied to Widener, and I talked with the head of the graduate program there, and she said, have you thought about getting your PhD? And I literally said to her, oh, no, I'm a nurse. I wanna care for patients. I want to support nursing practice. I don't want to be in academia. And so she encouraged me to think about it. And when they sent me the approval letter of like, you've been accepted into this program, it was actually being accepted into their accelerated master's to PhD program. And I didn't want to do it. I really thought, this isn't what I want. But I thought, well, I'll just try a couple of the classes and we'll see. And I am so grateful that I did that I took that chance, because going through the classes, it was like, you know, my brain was being changed. I could tell they were transforming the way I was thinking, the way I was approaching some of these clinical problems that I wanted to make a difference in. And so it really was just, the journey started there, not even, it was almost providential, right? It wasn't something that I was looking for. And while I was in the program to finish the PhD, I became a clinical nurse specialist. I had finished that portion of the program, and that was when I met Dr. Barbara Medoff-Cooper. So she was conducting research in the CICU and was really given to me as a mentor. And she really then very patiently, step by step, started encouraging me to think about clinical research, to then do a postdoc. And yeah, it was something that I really never thought was going to be in my future.
Yeah. So the grounding of your experiences and then just a series of exposures, that's fantastic. Mm-hmm. Well, Amy Jo, you're incredibly inspiring, and I'm hoping that this gets seen by a fair number of our nursing colleagues, because the work that you're doing is so critically important for the well-being of our patients, and you're defining the new practice of nursing heading into the future. So we need many, many more Amy Jo Lasantis.
Yes, we really do. And I guess I would close by just saying that I mean, I really had these assumptions of, you know, oh, those nurse scientists with their PhD, like they're way too smart. I could never do that. You know, it wasn't that I didn't think I was an intelligent human being, but it just was sort of this, you know, just thought that it never occurred to me. And I just continue to encourage nurses that when I look at them, I see myself 15 years ago, and I tell them, you know, you have the power to do this. I'm not that special. I work really hard, and I see that you work hard and that you care for your patients and families. And so we really do need to encourage nurses to reach for the stars. And you never know, because I've been a nurse 20 years now, and I never would have thought, but I'm hoping to have a good 20, 30 years left in my career. And so when I think about the experience that I can gain as a scientist will be even longer than my experience as a bedside nurse, that can be the reality for so many other pediatric nurses. So.
Well, we certainly look forward to some important contributions. So thanks very much, and thanks for your wonderful presentation.
Thank you.
And thank you all for your attention. Thanks so much for joining us. We are very much interested in your feedback, and we'd love to hear questions concerning our content that you've heard, as well as suggestions for additional topics that would be of interest to have reviewed in depth and discussed. In order to communicate with us, we have a dedicated email address. It's chophearttalks@email.chop.edu. We'd appreciate hearing from you. We'd love to hear your ideas and suggestions. Thanks so much for your attention.